So welcome everybody. This is Dermoscopy Workshop Part 2. Can I have a hands for anyone who didn't go to Part 1 this morning? Ah, a couple. Okay, that's fine. They're quite different presentations. The first presentation was given by my colleague here, Professor Peter Sawyer from Queensland. I'm a dermatologist from Waikato, and I have Emily, who's there at the back, assisting me today. Emily's a senior registrar in dermatology. So this part of the workshop is going to be more interactive, and with lots of exercises in how to recognize different patterns in dermoscopic diagnosis. We'll just put it in context, have a short test. I'll show you some dermatoscopes, and then we'll talk about modified pattern analysis for the diagnosis of some common skin conditions. And the most important thing is the ugly duckling sign. So starting with context. So the standards for service provision for melanoma patients in New Zealand was a provisional document produced by the Ministry of Health in 2013. Who's read it? Stony silence. Please go to the Ministry of Health's website, look at tumour streams, and download the documents for all the cancers that have been, standards have been written for. They're provisional because we can't meet those standards. For example, it says that we will see patients within 14 days in public hospitals, and you know that that's quite impossible. But that is the intention. So the standards include many things that are of relevance to primary care. Can I have a hands, please, who are nurses in the audience? No nurses? GPs? Other kind of doctors? Other kind of people? You are? Defence. Primary care type of work? Thank you. So please do read the standards and become aware that these refer to you and your patients. So firstly, that you will offer your patients evidence-based information on risk factors prevention and early detection of melanoma. So we need to understand who is at risk of melanoma and other skin cancers. But despite that, we know that in melanoma, 2/3 of patients might be classified as average risk for melanoma and not particularly high risk at all. Now, nearly all skin cancer is due to UV exposure, so we need to educate our patients in regard to protecting their skin from UV, whatever age they are. And this is mainly by behaviour and clothing with sunscreens as a secondary support. And we need to teach our patients self-skin examination. We're aware that 50% of melanomas are detected by the patient or a significant other. What we also know is melanomas detected by health professionals are thinner and better prognosis than those found by the patient. All primary care clinicians are trained to recognise skin lesions suspicious for melanoma. This is why you are here. You are here to learn how to recognise lesions suspicious. Now, we have to cut them out to confirm whether they're melanoma or not. As you've learned from Peter Sawyer's presentation, there are many lookalikes. So we need to firstly decide whether that patient needs follow-up by their risk factors. So a skin examination is necessary to determine if they have melanoma, whatever their risk factor. But if they're at high risk, you may then say, well, look, you really need to be on our annual surveillance, and we'll send you a reminder in 12 months to come for a check. And there is a new risk factor widget. Actually, I think it coming soon is out of date. I believe BPAC, if those of you who have BPAC for referrals, already has this risk factor tool incorporated into it. And it's very helpful for determining whether your patient who hasn't had a melanoma, because the risk factor widget does not work if you've already had a melanoma, needs to be followed up. Stay alert to incidental skin lesions when you're examining them for some other purpose. And if you are thinking that melanoma might be possible, that patient should have a skin examination from head to foot to determine what's normal for that patient, to see the pattern of moles and seborrheic keratoses and angiomas and freckles. Is it an ugly duckling? Well, you can't tell if it's an ugly duckling if you're not looking at the other ducklings. So standard 4.1 is that patients throughout the nation should have access to a patient who's skilled in early detection and diagnosis of melanoma, including the use of dermatoscopy. There is no excuse. Every primary care doc, every medical student should know how to hold and use a dermatoscope, at least at a basic level. I never want to hear again that a patient with a diagnosed melanoma had already been to their doctor on several occasions and had been told not to worry about what later turned out to be fatal. Digital dermatoscopy enhances skills. Now that means you need to be able to photograph. So it's all very well having a dermatoscope that you point and pretend that you know what you're looking at, but you actually need to record that as well. It needs to be recorded for the notes, and it needs to be recorded for referral, and it needs to be recorded for clinico-pathological correlation when you've actually excised a lesion, or your colleague has, to determine whether you can learn from that experience. The standards mention that automated diagnosis devices should not be relied upon. I have added a yet. And in fact, automated devices may assist in diagnosis. And everything changed in February this year with the publication of a paper demonstrating a machine was better than a dermatologist at diagnosing certain skin lesions, including melanoma. And for the first time, we can change and say, machines are here to stay, embrace it, jump on the train, it's going fast. And these machines will help you, but in order to help you, you need to have the basic skills to interpret what the machines are saying. So, you need a piece of paper, and you need a pen, and don't write on the cards in front of you, please, because they need to be recycled. And I'd like you to think very hard about the diagnosis of the following 10 lesions. Now, these are going to be dermoscopic views. It's just to get a warm-up. I'm not giving you the clinical views. There's no history with any of these patients. I'm going to turn the lights off. You should still be able to see. So I'm giving you 10 seconds only. And we have a machine that tells us how many seconds are going by. And I'd like you to diagnose the lesions. Now, you are given the same 4 choices for all 4 of them. You can imagine whether it's benign or malignant. Is it A, melanocytic nevus, B, melanoma, C, seborrheic keratosis, or D, basal cell carcinoma? Starting from now. Lesion 2. Three. 4. 5. 6. 7. 8. 9. 'And the last one. Now, I'm very conscious that some of you are beginners. Can we have a handheld of who considers themselves a beginner? Okay, that's most of you, so that's great. I will be moving fairly fast through this, but there are plenty of resources for you to gather information, and I believe this is recorded so that you can keep listening if you really must. I have a selection of dermatoscopes on the table over there, and we'll be happy to demonstrate any of those at lunchtime. There are more and more, so this picture is becoming crowded out and I can't fit any more on. Now, in front of you, you should have a white and an orange card. Could you hold up the white card, please? And the orange card. Great. Is there anyone that doesn't have white and or orange? Okay, Emily will come and bring you. So some of them are two-sided. Can you just turn it around? Sorry about that. It makes life more complicated, but we couldn't have it easy, could we? Okay, so option A is the white card, and option B is the orange one. So the first question is, who has their own dermatoscope? Okay, so I'm not seeing all the cards, but it looks as if it's half and half, so that's fantastic. More and more dermatoscopes are being sold worldwide. Now, by that your own, I mean your own. I don't mean the practice has one, because in my experience, the practice's one is in someone else's room, and the battery's flat anyway. So you do need your own. So, as well as option A and option B, I thought I'd make it a bit more complicated and have the third option, which is option A plus B. Could we just have a demonstration of A plus B? Thank you very much. Great. Very good. And as if 3 options wasn't bad enough, I'm going to give you the 4th one. Okay, so option 4 is that none of the options are true, or I don't know, or it's not applicable. So can we have a demonstration of option 4, please? Great, because if you don't, we're all going to be delayed by you not doing it, because I'm going to be looking, and then we won't get to the end. And since I have 300 slides, there's going to be an effort. Okay. It's very annoying the way this is showing, isn't it? I wonder if I can get rid of that somehow. Do you know how to do that, Emily? Right click on it. Right click on the bottom. Yeah. I did that. Unclick it. Brilliant. My dermatoscope is A, B, A plus B, or neither. Now remember, those of you who don't have a dermatoscope are supposed to be doing this. Why is it that I always have to remind people of that? Okay, so quite a lot of you don't know. So I'd say there are fewer people marking that one than there should be. Which dermatoscope should you get? Well, of course, it depends on your budget. Now, we do have one for sale at this conference for $26. Now, that's only 3 or 4 cups of coffee. I think we all should be able to manage it. No, it's not the best dermatoscope. But in my opinion, the best dermatoscope does not require $2,000, which you could pay, or more. So the choices are whether they're polarized or unpolarized, or better still, both. And both generally means more than $26. Contact or non-contact, and the ability to attach to a camera. And I really think those things are very, very important. But the actual size and quality of the lens turns out to be not very important. The portability may be important. So, for example, in my situation, I'm going from room to room, I rush up to the wards, I need something that will sit in my pocket or clip onto my belt. And how you charge it is a personal thing, but preferably USB these days, because we've all got a computer in front of us and we don't want to rush around looking for charging devices. So a non-contact device. Emily, we need you holding up the non-contact device. The Lumio is to be demonstrated for those of you, and the one next to it, the smaller Lumio. Yeah, those two. So these are non-contact devices, and they're designed for quick examination of the whole patient. So most people's consulting rooms are not light enough. Or you have light coming from the top, and you have your patient standing up and you can't see their legs. You need a bright light. Most of us do require magnification, and those two are polarized. So the larger one is ×2 magnification, quite enough for a quick check, and the other one is ×4, and obviously the smaller one is less expensive, and they are expensive. An ordinary magnifying glass is not really enough. It doesn't act as a dermatoscope because it doesn't have that quality of reducing the reflection from the surface skin. If you've got a contact device, that means that the device must be in contact with the lesion that you're examining. And in order to see what you need to see for dermoscopy, you must apply fluid. So you remember with microscopy in the old days in medical school, you're looking down these two holes and wondering what on earth you were supposed to be looking at. When you went to the ×100 magnification, you had to have oil immersion. And that is true for contact dermoscopy. It doesn't need to be oil, it can be alcohol, which is much more convenient, but it's a pain in the neck. So what do you have to do in using a contact dermatoscope is every single lesion you must polish. Oh, there's a polishing cloth there, but I haven't put it out. It's actually in my bag. The bag with all the dermatoscopes in it has a plastic bag in it with polishing cloths and various selections of alcohol and so on. So you could use, for example, the gel that you have for cleaning your hands. So you would polish the lens, and then you use a polishing cloth immediately because you don't want the alcohol drying on the lens and leaving smudges. And then you put alcohol on the patient, and then you put your lens on top of the lesion for a good contact picture. And you've got to do that with every lesion because there's smudge. And the problem with that is it's a pain in the neck. But you get much better images with contact and fluid. But polarized options do not require the contact and they do not require the fluid. Therefore, much quicker, much easier to use. However, not so easy for photography. So what do we see as a difference? So these two pictures show two lesions. This one at the top is a melanoma, shown by polarized view and unpolarized view. So the polarized view gives us much better structures around the edge. You can see those nice little dots around there. But the unpolarized view is giving us more surface interest. In fact, you can see a big bubble of fluid on there, and more colors come in. Now, this is a benign nevus, but it's a bit fuzzy, and it looks as if it's not in focus. Actually, it's in perfect focus, but what has happened is the lesion is distorted, and a fuzzy image might be a melanoma. So one of the characteristics of melanomas are they look unfocused. But this is not a melanoma because on the unpolarized view, we can see it's a normal nevus in the background. It's just got a blister on the surface. So it's very useful to have both methods. So ideally you have both. Now, for digital dermatoscopy or photography, you obviously need a camera, and you need a dermatoscope, and you need some means of putting them together. So you can just hold them together, but it's extremely difficult to get a decent picture, so it's much better to have some means of fixing them. And the other thing I've forgotten is the means to fix things. But here are some examples. This is an SLR camera with a dermatoscope on the end and a little adapter between them. Here's an iPhone. This one's an iPhone 4 with a DL1, which we've got over there, and it's been converted from the, have you got the two DL1s? So the DL1 without, maybe we will need the light on. So the DL1 that you hold normally, and then when you convert it to photography, you add a spacer. So it comes from an non-contact to a contact device. It's easier to demonstrate when you've got two. And those actually join on just by a magnet, so you just go smash, join them together. Very easy. And then you need software in order to display it. Now the software may be on your camera, on your portable device, it may be on your desktop, or all of those things. And you need it for sharing as well, because there's no point in taking a photograph if it's not attached to the patient's record, if it's not available for the pathologist should they need it, or to referral. Now, many of you, I believe, may need to use photographs to get referrals to your public hospital. Can you have a hands held of who needs to send a photograph? Okay, so you're familiar with this. Now, the rest of the country hasn't caught up. We haven't caught up in the Waikato. It's still optional photography. But I can tell you, your patient with photographs is going to get prompter attention, or less prompt, of course, if you send a picture that shows us we don't need to be concerned. So the next question is, I have photodermatoscopy. Yes, no? Both? That doesn't make sense. Or I don't know, or neither, or don't forget. That's great. So again, we've got about half of you can take photographs, and that's brilliant and new, because until recently, people were using dermatoscopes in textbooks, and there was not much correlation between the textbook and the dermatoscopy because they weren't recording the device, the results. They had no idea from histology whether what they saw clinically was actually what was. I'm sorry, what's happened here? I'm sorry about losing the bottom end. I had rather a quick look at this. I converted from original format to 16 by 9 that was required for this workshop only last night, and I clearly didn't do a very good job. So you could buy an SLR camera, but I counsel you against us. The SLR results are actually much less good than the others. But if you love photography, that's what you may choose to do. And the lenses are around $2,000 to $3,000 for a dermatoscopic lens. And it's really rather a shame that you spend all that money and actually you do better with the $20 one. So a compact camera is what we've been using over the years. The current ones that are recommended for use with the DermNet range include those. Some of those are older models, but they still work. And I haven't updated this year, so this was last year's information. So you can have a dedicated dermatoscopy camera. So does anyone have a DermNet cam here? Lara was here before, she certainly does, and we have one at Waikato Hospital, and several of our referring practices in the Waikato have purchased these. They're extremely expensive, but they're very convenient because you take both the macro, the polarized and the unpolarized picture, and there's a means to send them for a second opinion. So most of you will have smartphones. Hands up who has a smartphone in their pocket? Almost everybody. That's good. So you've all got a camera in your pocket, and the world has completely transformed over the last year. It's interesting to imagine, isn't it, that the first phone camera was in the year 2000. That's only a few years ago, and yet now it's absolutely ubiquitous. So the dermatoscope people have finally caught up with this, and it doesn't matter what dermatoscope you have, what camera you have, you can find a dermatoscope to fit it. Can you show the hood? So the hood has the hood is designed for the consumer, but it has a variable device that will fit every smartphone. So you don't have to buy a specific device adapter. And increasingly they're producing flexible ideas like this. So these are some examples of the different things that you can get adapters for. Now the newest, smallest solution from First Check is a skin soap that is tiny, easy to lose, doesn't have a light, doesn't have a battery. Good. Nothing to, if you don't have a battery, it can't go flat. But you need a lot of light to use it. It's not polarized. It must be used in contact, and it's extremely small. So don't expect the results to be the same as what you can get with a larger, more expensive device, but it may be adequate. Now, it's not designed for doctors. It's for consumers. So the expectation is that you will actually sell or give these to your patients at high risk, or the ones that keep coming every third week with another spot for you to look at. Say, right, why don't you use this, take photographs, send them to me by email, and I'll let you know if you need to come in and for me to have a closer look. So my current number one favourite is the Molescope 2. Which is a device that's polarized. Molescope 1, Emily has Molescope 1 in her left hand, and she has Molescope 2 in her right hand. The Molescope 1 is unpolarized, the Molescope 2 is polarized. The Molescope 2, you can take off the front, you just remove it, just put your nail under the... It just slips off and becomes a non-contact device. You put a different thing on it. And this has got very high quality pictures. So although it's low cost, it's 299 Canadian dollars, it is very simple to use and the image quality is exceptional. What's more, it comes with the most amazing software in dermengine.com, and yes, I'm paid to tell you this. Actually, I'm not paid, but DermEngine is partnering with DermNet New Zealand and providing us with some technological expertise and some very exciting things you will be seeing on DermNet New Zealand very soon. So software is very important. Now, as promised, I'm going to talk to you about modified pattern analysis. Those of you who are here this morning learned that there were two types of pattern analysis: conventional, which was described in 1987, and Peter Sawyer was in the first group that looked at that. And then more recently, Harold Kittler, who's also an Austrian, decided to make it simpler. And that's the system I like to use, because there's nothing better than thinking simple. So pattern analysis was shown to be the most effective way to make a diagnosis of skin lesions using dermatoscopy. And there have been a number of papers that have confirmed that. And what we learnt, that if dermatologists were trained in pattern analysis, they were much more effective at diagnosing skin lesions, and their number needed to treat dropped because they could exclude benign lesions and didn't need to cut those out. So pattern analysis talks about global pattern, and Peter talked about reticular, globular, homogeneous, starburst, parallel, complex, and multi-component patterns. I think he called the complex pattern non-specific. And then local features that we look for to make a diagnosis of melanoma. But you have to understand what a streak is, or a blotch, or a comma, a pseudonetwork, lattice, and fibrillars. So words that need definition, and if once you've defined them, you've got to try and remember them. So when we're talking about a melanoma, we've got a longer list of things to look like, and we're expecting the global pattern to have 3 or more structures in most cases. So the consensus conference in 2016 compared these two methods and asked hundreds of dermatologists and other, so primary care dermoscopists as well, to say which of the 300 terms were known to them. And it turned out that actually most of these 300 terms, most of the dermoscopists have never even heard of. We didn't know that there was such a thing as a sunrise pattern, for example. So the group compared modified and the conventional pattern analysis and came to the conclusion that the modified one was easier to use, but the conventional one was much more fun. And because metaphoric terms like starburst or strawberry, it's just like saying an elephant's an elephant. We don't say an elephant has 2 ears, a long trunk, and 4 legs and a tail. We just say it's an elephant. And so in the same way, we can say that's strawberry pattern. Whereas with the modified pattern, we have to say there's a yellow dot inside a white circle, around which is a thick, out of focus, reddish, curved line. So a strawberry is a little easier. So metaphoric dermoscopy is full of interesting words like contrail, lacunae, serpentine, chrysalis, rainbow, and so forth. Now Harold doesn't like these. He's got all sorts of terms to say why he thinks they should go. So Harold's idea was that you should just look at what the lesion looked like and decide whether to excise it or biopsy it. So if we're talking about, is this a melanoma, we are referring to, does this need to be excised with a 2 mm margin? There is no other option. If you can't excise with a 2 mm margin, then you refer to someone else who may have better diagnostic skills or can do the bigger surgery. So modified pattern analysis starts off with skin lesions are made of structures, lines, dots, and clods, and there are structural zones. So if you can't see a line or a dot or a clod, and that they have varying colours. Now, Emily's got a list of people attending this. I haven't had time for you to introduce yourselves, but she's going to randomly pick on a name. Now, I'm very mean and horrible and ask you to contribute for interactive stuff. But if you really can't cope with this exercise, just say pass. And we'll move on to the next victim. Who's our first victim?
Alice.
Where's Alice? Alice, I'd like you to look at the ceiling. Not too difficult. I want you to describe the ceiling in terms of lines, dots. Okay, so you can see some dots in the middle of what? Okay, so we've got, the squares are made up of, they're lines, okay? So we've got intersecting lines, and if you can look very closely, there are tiny, tiny dots visible. Do you see anything we might call a clod? Now, that's just a lump of earth. Earth. So a lump of earth could be roundish, it could be elongated. Between the lights, so you mean this thing up here? We could say that's a clod, that's a white clod, yeah. We could call that sort of a clod, two clods on top of each other, and this is a clod. This is a bigger clod. Alice, do you see any circles? Around here? Okay, so a circle, I haven't got that on the list, I only said lines, dots and clods, but a circle is a line joined up. So this is a line joined up, makes a circle. And can you see any structureless zones? Well, you can't see any dots, you can't see any clods, you can't see any lines. Or the wall? Yeah, okay, so the wall is a structural zone with some lines and some dots inside the lines. Okay, so the whole world can be described as lines, dots, clods, and structural zones. But they have varying colours. The ceiling's a bit dull. Dermoscopy is much more exciting. We have pinks and browns and blacks and blues and greys and yellows and whites. That's it, really. That's modified pattern analysis, or at least the basic elements for it. So we can put those elements together and say they form a pattern. So we've got these crisscross intersecting lines here, and we call that a reticular pattern. It means a network. So we have a reticular pattern as our background, and we've got a few clods scattered on top of it. Now, if you have a nice, neat pattern, think of a nevus, or maybe one or two of the other lesions that we're going to discuss. If, on the other hand, they're all over the place, and there's a line here, and there's a dot there, and a clod in the middle, and it doesn't make any sense, and you've lost that pattern, it's cancer. And if we're talking about melanocytic lesions, we're then comparing the nice, neat pattern of a melanocytic nevus with the disordered chaos of a melanoma. We can have SEBKs, and they're tricky ones. We'll come to that. So lines can be recognized as reticular, or branched, or parallel, or radial. So radial means it comes out from the center, and you can have curved lines as well. In this case, they're curved parallel lines. So the reticular pattern is due to deposition of pigment in the keratinocytes. It doesn't tell you that it's melanocytic, because that pigment is actually in the keratinocytes, not in the melanocytes. So we can see it in solar lentigos, which are keratinocytic lesions, and we can see it in nevi, which are melanocytic. You can actually see it in normal skin. The normal pattern in darker skin types is reticular pattern. Now the lines can vary in thickness, and the holes can vary in size, but they should be uniform across the lesion. Now, here it's a bit denser in the center, but basically the pattern around the side, this has the same sized lines and the same sized holes roughly, and they just get a bit denser in there. This is a completely different lesion, and the lines and holes are much smaller, and it's more dense in the middle. And in this case, it's a repeated pattern of lines. And here, the lines around the outside, and you actually lose them in the middle. So those are all described as reticular pattern. Okay, which of these two is reticular pattern? A, which is white, B, which is orange, A and B, which is orange and white, or neither? Can you see intersecting lines? And Emily's going to choose the next person to tell us which they chose and why. Kabir? A and B, yes. And why did you decide A and B? That's right. So not dots, but lines. So intersecting lines. Hope everyone can see them. If you're having difficulty at the back, there's plenty of chairs at the front. So this one is more of a repeating pattern. If your eyes aren't very good, you might just see brown pigment. Probably doesn't matter. The main thing to note is that that pattern is the same all over. And that pattern is not quite the same all over, but basically the brown bits. This brown bit is pretty similar to that brown bit. That brown bit's bigger, but it's really got the same pattern. So both of them are benign. They're both congenital nevi. So this one's known as a speckled, because of the repeated pattern. Lentiginous, because it's flat, nevus. And this one doesn't have that description. Both have hairs growing out of them. But in this case, it's an integral part of the lesion, and this one, it's coincidence that happens to be in a hair-bearing area. Okay, which has a reticular pattern of these two? Okay. Chandra. B. So, are you going to tell us what kind of pattern you can see, remembering that we've got lines? Emily, perhaps you'd like to do some drawing of some lines, some dots, some clods, and then structural zones. Which of those has this got? Yes? Regular pigmentation. Irregular pigmentation in terms of distribution of the colour? Yes. Yes, it's true. But what structure is it? No, a circle is a line joined up. Can you see a line joined up? It's a round lesion, but the structures... So, in fact, you can't see any structures here. We're not seeing any lines, and we're not seeing any dots or clods. We're just seeing irregularly distributed pigment, which actually makes it a single pattern. Yes? That one? Right, not enough. When we're talking about a pattern, we actually, I should have mentioned this, we're really talking about a pattern that affects 30% of the lesion. Otherwise, it's a local feature. So this is a pattern of lines. There's a local feature here where the lines are missing. This is a structureless pattern, and there is a local feature of the odd dot or clod here and there. Yep. You mean you're talking about this? The brown bits are all intersecting lines. Emily's drawn intersecting lines here. Maybe you need to come closer. It's a bit like the vase and the faces. When you're first starting, you're very inclined to see the holes. But actually the holes are the absence of pigment, and they're not the structure of the lesion. They're the background. And it's the pigment that we need to consider as being our structure. So thank you for drawing that to everybody's attention, because half of them were thinking, I see dots all. Yeah, come up to the front, please do. It's a nice small group, so you can. She has drawn a grid, but that's a geometric approximation to nature that doesn't form geometry.
So what I see is like a doodle,
Okay, so you can have joined up circles if you wish.
Yeah.
Yeah, it comes to the same thing. It absolutely comes to the same thing. And I think I've got a picture later on that demonstrates exactly that. Sometimes you've got that circles joined up, and sometimes they're more of the grid. But they're both called reticular pattern. So this one is a blue nevus. Does anyone notice anything funny about this blue nevus? This blue nevus? It's yellow. Yes. Emily, do you know why blue nevi are sometimes yellow? Maybe, but yes, the deeper pigment is blue, but these are deep cells that are not producing pigment. Okay, so a blue nevus is a collection of cells deep down in the dermis, right down in the reticular dermis. And they're actually spindle cells, and they're different from the normal nevus cell, which is a rounded thing. And in blue nevi, they usually produce a lot of pigment, which looks blue. But like any other kind of nevus, they can lose the ability to produce pigment and fade out. And a normal nevus fading out looks skin-coloured. But a blue nevus fading out looks yellow. So that, if you see a yellow nevus, think blue. Luckily, mostly they're blue, just to make it easy. This is exactly the pattern we're looking. Does that help? That both these kind of structures are acceptable as reticular pattern. Okay, now we're on to the next kind of line. Which of these has branched lines? Okay, who's next from your list? Michael? Yes? Okay, so branched refers to a pattern. It doesn't tell us what colour it is. And in this case, we've got branched red lines. And most branched lines are red, just to make it easy. Can we have a picture of a branched line up there? Thanks. Perhaps in red? So this isn't a diagnosis, it's a pattern. Same as this is a pattern. Now, these are parallel lines, and we'll come to parallel lines in a minute. Would you like to make any other comment, Michael, about these lines on this one? It is an acral nevus. Parallel in the furrows, so that means they're going along that way, between the ridges. Yep. No, you can't have a reticular pattern. I was hoping you'd say that, because you can't have a reticular pattern on the palms of or the soles. So when you have this fuzzy pattern, it's not called reticular. In fact, this is called fibrillar. But what we have, in fact, is lines going in the other direction, but they actually form more of a lattice when they do join up. These aren't joining up, and when they don't join up, they're just called fibrillar, and when they do join up, they're called lattice. Do you understand the difference, lattice? It's like bricks. If you can draw some bricks, it'll be the lattice. Yes, exactly. So on the soles and the palms, if we do see lines going in the opposite direction, they're usually at an angle, actually. They form that lattice. So if you do that again and with an angle to it. Yeah, that's better. Great. Okay, so we've found out parallel lines, and we see parallel lines in the soles and the palms, and those are conventionally known as acral. Acral actually also includes the nose and the buttocks and the ears, but acral pattern nevi are the palms and soles. So let's have some hands up, or some white and orange tags which of these has parallel lines? Okay, most of you, did you not get 2? We'll get you another one. Difficult to hold up 2 when you've only got 1. Who's next, Emily? Stephanie? Stephanie, which did you see as parallel? B? Okay, and what can you describe what you see? Pigmented parallel lines, that's precisely right. Now we learnt from Michael that they might be in the furrows or on the ridges. And do you have any idea whether we're looking, Stephanie, at lines that are in the ridges or in the furrows in this picture? Right, so just hazard a guess as why you think they're in the furrows. Would anyone like to contribute to this? Tell us why do we think these are in the furrows? Any clues? Furrows versus ridges. So we're talking about mountains and valleys. So if you look at your hands, you can see you've got mountains and valleys on your hands, fingerprints and so on. No glands. You've almost got it right, but they're not glands. Little white things, these dots. Yeah, they're actually not glands. They're deep down in the skin. They're actually the pores from the ducts. Okay, so there's the sweat ducts. Okay, and are they on the ridges or on the furrows? Yes, that's right. So, if let's go away from the knee. It's perhaps easier to see. You may not all be able to see it, but you should see a little row of white dots. And the white dots are on the ridges. And so if you go closer here, the white dots just discernible. And that tells us that the pigment is in the furrow. And that's good news, because furrow is fine. Furrow, fine. Ridge is rotten. Furrow is fine. Okay, what about this one, Stephanie? Do you have parallel lines? And if they're not parallel, are they branched, are they radial, or are they reticular? Because those are your choices. Oh, no, they're not pigmented. I just said other lines. Okay, so there are parallel lines here. What colour are they? No, the lines are skin coloured between what? You always remember that I'm not going to talk about skin colour because that's background. I'm going to be talking about a colour. So the colour is red or purple. So what do you know that's red or purple or blue? Vascular. Okay, so this is a vascular nevus, this is a pigmented nevus or melanocytic nevus, this is a vascular nevus. And we have a double parallel pattern. In this case it's made up of dots. So it's a double dotted ridge pattern. Here we can see the white dots much more clearly, telling us that the vascular nevus is hugging the ridges and the furrows are not involved. So this is a ridge pattern, but it's entirely harmless. It doesn't mean it's cancer, because this is not pigment. This is vascular, and that is unchanged. I've got other pictures of that. It's completely unchanged since, presumably birth. Well, what about radial lines? So radial lines are lines coming out from the centre. Which of these two has or have radial lines? Okay, very good. Most people have selected both, which is great. If you haven't, please select both. Emily? Ruth? What did you think? I'm going to give you the pointer. You can point at the radial lines you can see. Okay, so the radial lines around that lesion are all the way around circumferential. And what about the other one? and then they stop. That's right. So they're only partial. Let's have a look at the diagnosis. So this one has radial lines all the way around, which makes a symmetrical pattern, and this has them around somewhere. Asymmetrical. And looking at this lesion, can you hazard a diagnosis for me? Go on, be brave. This is a melanoma. No need to be concerned. You can be confident. So this melanoma is interesting. What about the background? Yes, we've got a reticular nevus. So we've got something with a radial pattern that's fallen on top of. So it could either be a coincidence that a melanoma has coincided with a reticular nevus, or that the reticular nevus has grown a melanoma. Now, both possibilities are true, or I don't know about in this one, but the research has shown that melanomas can just land on nevi, or they can arise from nevi. And we know that from oncogenetics. So the radial pattern means the lines are coming out from the edge. But we're also seeing that the beautiful, even reticular pattern is replaced by an uneven, chaotic, multicolored, well, at least it's got black and a kind of bluish-grey colour, and that these lines are not the same. They kind of disappear here, and they've got clods on the end. Can we have a picture of a line with a clod on the end? Does anyone know what a line with a clod on the end is called? A pseudopod. And this has the same, but this is benign because it's all the way around. This is a very rare kind of nevus. It's pigmented spitz nevus, or if it's black, a red nevus. This one is brown. It's a pigmented spitz nevus, and we generally excise those in adults because they're ugly ducklings, they're solitary, they grow, they upset and make us all nervous, and it's much easier just to cut them out. But in children, cutting something out is quite a burden to the child and the parents, and it may not be necessary. So I would share that burden by referral to a pediatric dermatologist if you're lucky enough to have such a person. So asymmetry of structure, sometimes known as chaos, and symmetry of structure. So with the pseudopod has reminded me to say that we've not only got line structures, but we've also got rounded structures, and rounded structures can be pseudopods, a line with a clod on the end, circles again, which are really joined up lines, clods, which can be any colour and any shape. If you think of a clod of earth, it really means it has a shape, though. So if you don't, or you can't describe the shape, we'd call it structureless. And if you can describe the shape, we'd call it clod. And if it's too small to describe the shape, it's a dot. And dots and clods join together in many instances. So here's some pseudopods. We have all the way around in this reed nevus. See, compared with the pigmented spitz, this is a black one. This is in a child. It's a benign lesion, but it looks very peculiar, and off it came. So we could confirm that histologically. Here we have a melanoma. It's disordered in structure and colour, and it's as easy as that. That's all you need to know, disordered in structure and colour. And this one has some radial lines, some of which have got little clods on the end. I think it's very difficult for me to see at an angle, but I think you may make them out just there. Okay, which of these two has pseudopods? Just to make it easy for you, it's only one of them. Okay, and up they come. Who's next? Rebecca. Which, you've chosen the one on the left. Why? Okay, so we've got a reticular pattern with a dot on the end of the line. That's correct. So a pseudopod comes from a structure. You can't have a pseudopod isolated in the middle of nowhere. It must come. So that's very good observation. And that's usually how you'll see them, a pseudopod on the end of a reticular pattern. Now both of them are melanomas. This is a much more common pattern of melanoma. In the New Zealand skin, which is the sun-damaged skin, we do not see pseudopods very often. They're a reflection of the superficial spreading melanoma, whereas we tend to see more lentiginous melanoma, which is sun-damaged melanoma, as opposed to the nevus-associated melanoma. So people with funny nevi develop a certain type of melanoma, and people who've basically ruined their skin by frying develop this kind of melanoma over here. And they have their own distinct patterns. And so circles sometimes form patterns too. Circles are often you just see a few circles. So in this case, we're seeing a sort of reticular pattern made up of circles. What's your name? Louise pointed out to us earlier. So Louise pointed out that it's pretty difficult to see a reticular pattern when it's made up of circles. And here's a more exaggerated example of that. But in fact, this is a seborrheic keratosis. And what you're seeing is little fronds of dry stuff on the skin surface where the edge of those is a bit more prominent. So it shows up as a circle. And these paler pattern ones are the same. Now, in this lesion, we've got a squamous cell carcinoma, and squamous cell carcinomas are sometimes characterized by white circles. So that means they have to have something in the middle. They're not clods. So a white clod would be around. Can we distinguish the white clod from the white circle? I think you might need to use 2 pens to do that. So here we've got a white circle, and inside it is a slightly yellower structure. That makes it a circle. So in this case, we're seeing quite a few of them. And that is a characteristic of a well-differentiated squamous cell carcinoma when it's first starting. They do lose these as they become more advanced. Right, so there's the circle, and there's the clod. It's green in this case. We only see green when it's a bruise that's gone through the green phase, not a common colour. So what about these two? Which of these two has circles? Should be easy. Yep. Who's next? Anna? White clods? Actually, we call them skin-coloured. They're not very white. They're the colour of the surrounding skin. So that's an important differentiation because white means cancer, often, or fibrosis in the dermis. And here, we're not actually seeing white, we're just seeing the normal skin colour, and which might be white skin. And you will become familiar with the difference as we go along. So this is skin-coloured clods with brown circles around them. Now, Anna, how can you describe this? No, it's not structureless. There are plenty of structures. Don't think about the background. Forget the background. Okay, black dots. Just for your information, these are grey. Now, we've recently done a research project where 3 dermatologists tried to decide what colours things were, and we found grey very difficult to agree on. But we would all agree on this being grey because we recognise the pattern, and that's a grey pattern. So when you see lots of dots like that, just remember they're grey. Even if you see brown or black, they're grey. So the entity that is forming these grey dots is known as a lichen planus-like keratosis. What a silly name. Emily, do you know why it's given that name? Good idea, but wrong. Lichen planus doesn't have grey dots. No. It's entirely histological. And the histology of the lichen planus keratosis cannot be distinguished from lichen planus. They look identical. So if you cut this out, you'll get a diagnosis of lichen planus, and you will lose all faith in your pathologist. Because it was a solitary, probably a little bit of a scaly lesion, and probably the patient told you that they had a lesion on their hand, and it went purple and itchy, and now it's grey, and they're worried it could be cancer, because it's changed. And you see grey dots, and you can say, yes, this was a solar lentigo, it used to be brown, and you're losing the brown solar lentigo, and I can tell you, you're going to lose the grey dots too. They're going to disappear over the next few months. Do you have a question?
Just what is the white?
I see no white. In this one?
On the one on the left.
The one on the left. No white. Skin coloured?
bubbles.
Okay. They're bubbles. They're exactly that. So if you recall, I said to take good pictures, you need fluid on the skin. And isn't it funny that when you're used to looking at them, I can't even see those bubbles because I'm not looking for them because I know they're there and they're just in the way. Just like you don't notice that, whether a cat has big ears or small ears, they're just a cat. Okay, so dots can be grey. This is another one with grey dots. Very similar. Again, you might be seeing black or brown, but just believe me, it's grey. And these ones are red dots. So what are red dots to you two? Blood vessels, yes. Everything that's red, basically, is blood vessels. And does the fact that it's a dot tell us anything more about the blood vessel? The way they've been cut, maybe? Emily? The direction, exactly. So a capillary going vertically, we see as a dot. Whereas a capillary going horizontally, we see as a red line. If it's a venule, it's going to be what colour? Blue. Okay? So we can see red dots from capillaries and red and blue lines. So the dotted pattern tells us where the pigment is deposited. So red means vertical blood vessels, black means pigment in the epidermis, and that's usually meaning in melanoma, but not always. We do see deeply pigmented skin developing nevi with black dots on the surface. And that's because of so much pigment produced. And the pigment goes up into the keratinocytes and then disappears in the bath. Brown means that the pigment is in the junction between the epidermis and the dermis. Grey means it's in the papillary dermis. So that's why we can say that the grey dotted pattern is destruction of something. So we see collections of grey dots in melanoma, but they're focal. And we see them in the lichen planus like keratosis, and they're beautifully scattered in a symmetrical pattern. And blue, in the blue nevus, means deep dermis, but that's a structureless pattern, and if we see blue dots, that tells us that there's melanophages deep down. Do you all know what a melanophage is? It's basically a macrophage that's full of melanin. So it'll disappear. So the melanins drop down into the papillary dermis, the macrophages will come along, chomp them up, and they're going to take them away. And the melanophages seeing that process in thing. So here's some dotted patterns. We've got the grey dotted pattern from the lichen planus like keratosis. We've got the brown dotted pattern on a broken up pigment network due to a ink spot lentigo. We've got a pink dotted pattern. This is in fact another vascular nevus, and that'll be stable for years. And we've got a brown dotted pattern in this benign pigment nevus where the dots are around the edge. So dots, brown dots can be around the edge, they can be in the middle, they can be scattered across the whole lesion. Which of these two has a dotted pattern? Yeah, it's not that hard really, is it? Some of you are holding up both. Just put down one. Can we just all hold up one colour, please? Yeah, that's better. But turn it round so it's facing the right way. I'm sorry some of you have got these very confusing double-sided ones. So obviously the dots are on the left, and they're both benign. They're just different type of nevi. So this has got a paler centre, but it's not a white centre. It's hypopigmented, if you like, but it's actually the colour of the background. So the pigment is in the periphery, and there's even dots around that. This is actually congenital nevus and stable, as opposed to the dots around the nevus that Professor Sawyer showed us that represent an enlarging Clark nevus. Do you know what I mean by a Clark nevus? It's another name for a dysplastic nevus. Dysplastic nevus is just a benign nevus. It doesn't mean anything. Don't think dysplasia means it's about to turn to cancer. It doesn't mean anything of that sort at all. It just means it's a type of nevus. It's a superficial type of nevus. Yes, actually, you probably can't. The lines are very fine in that one. No, this isn't a. You will see more clearly that the clod pattern is very distinct edge to it. You see how Emily's done a very distinct clod here? There's no question about it. This is kind of vague. And do you remember we saw that other variegate nevus? It's again, just so I knew that was a grey dotted pattern. I know this is a reticular pattern. It's just the pattern of nevus. And so what happens if you expose a nevus to the sun as it changes? So we did a study of patients with psoriasis who were undergoing phototherapy. And we imaged their nevi before they started phototherapy, during phototherapy, after they finished, and a few months later. And we saw that 50% of the nevi exposed to narrowband UVB altered during treatment. Most of them returned to normal, some did not. And the alteration of the reticular nevus was it lost its clear reticular pattern. It became more fuzzy. So I can say that this nevus has probably had a bit of sun on it, and that's made it fuzzy, so you can't really see the reticular pattern anymore. Doesn't mean it's not a reticular nevus, it's just it's fuzzy. So a clod can be any colour. We can have light brown, dark, well, not any colour, but these colours. This is blood, and that's forming clods. And they have a reddish tinge. They're often a sort of brownish, reddish, blackish tinge, but they do have that definite red part to them. This is well, that one, I think it's a nevus. It's either a nevus or a seborrheic keratosis, but it doesn't really matter. So the clod pattern, again, it doesn't really matter whether they're clods or lines or whatever. We're really looking to see whether we need to cut this lesion out. And it's symmetrical. So this is a clod pattern nevus. This is a clod pattern seborrheic keratosis. The pattern is the same all over. There's some difference in the density of the colours, but it's more or less the same. It's a single pattern. Some of the clods are bigger or smaller, but they're still clods. So maybe we need to draw some clod pattern. That's to say, lots of clods. They can be varied in size and maybe varied in shade, not colour exactly, but some darker than others. It's still a single pattern. So these are both clod pattern, well-defined structures. You could describe the shape. You could say they were round or oval or rhomboid or polypoid or four-sided or whatever you wanted to do, but they have an edge to them. These large ones in conventional pattern are known as cobblestones. So I will use this term cobblestone because I know what it is. Those large clods all joined together like a jigsaw puzzle or a cobblestone. This pattern is of much smaller clods. They're all the same colour in this case, some variation in the size, but basically single pattern. And some of this pattern will turn to this pattern of age. So a child has this pattern. We don't see this very much in adults, so something must happen to it. And what we know happens is at least some of them become what we see here. So they become from flat nevi to papillomatous or bumpy papules. Which of these two has clods? Okay, we should be holding up orange. Can we have, who's next? Suzanne, tell us about, you've got orange up, so.
The one on the right has joined up clods.
Yep. Well, they're not quite joined up. Well, they're
Separate.
Yeah, they're separated. Yeah, so it's all exactly. So there's same sort of thing here as here. They're not identical, but similar in pattern. What about this one here?
Hard to see.
Yes. Good. So that means it's
Skin-coloured, round.
skin colour. I see something not skin colour.
Bluish.
Bluish. Yeah. Does that give you any clue what it might be? Bluish. Yeah, well done. Blue nevus. So a blue nevus is fuzzy because it's deep down in the skin. So it's difficult to see. It's exactly the description. Ground glass appearance. It has that blue tinge, but it's not blue all over because we have that yellow bit that comes in. I think maybe you can see just a touch of that in some of the lesion. Ignore the non-coloured parts. These don't really count, but they might be white. The main structure is that ground glass, steel blue colour, blue nevus. Easy. Probably you were all terrified by Peter Sawyer showing you a cellular blue nevus that turned out to be a melanoma. Look, that's as rare as hen's teeth. Don't worry about it. Most blue nevi are easy. They just look like that, and they stay like that. Okay, so structureless. So we've had the blue structure, you can have a brown structure, you can have a skin-coloured structureless. So you may have a little bit of something. So here we've got a few lines, but that's a local feature. The pattern is structureless. There's a few more lines. It's a structure. It's got several zones, in fact, 3 on top of each other. And this is all brown. If you look very closely, some of you may see lines, but actually the lines we're seeing there are due to the skin being a little bit thickened in that zone where that picture's been taken, and not from the structure of the nevus at all. Which of these two is or has structureless zones? Great, well we've got some variations. Some think it's white, and some think it's orange, and some think both. And who do we have? Sally, what did you choose?
I chose that. The first one. Because there was just such a sort of mix, you couldn't really define anything.
All right, so there's no dots and there's no lines, no clods. And dots and clods go together, so there's no lines and there's no dot clods. So we call it structureless. Absolutely. We've got different zones of colour. How many zones do you think you can see? At least 3. So this is probably another blue nevus. It's hazy. We've certainly got a little bit of ground glass appearance. It's totally the wrong colour and would probably get excised because it's very unusual looking, but it's actually symmetrical in pattern. It's obviously benign. It's a stable lesion, hasn't changed for years, and on excision. Well, we didn't excise it, but I'm guessing it'll be a blue nevus, just a rather unusual one. What about this one? Are there any zones that are structureless? Sally?
Zones around the outside.
Okay. Exactly. So the outside is reticular. And the inside, some sort of dotty things going on. And then there's this intermediate zone. If you examine this intermediate zone, how would you describe that? And therefore, this word up here? Yeah. Okay, so this has got 3 zones. It's symmetrical. It's got a reticular pattern. It's got either clods or dots or dot clods. But this zone in between is structureless. And this is known as a coccade nevus. So nevi can be multi-component. In this case, we've got another one of those ones rather looking like the other one, with a central blue-grey colour. This is artifact here from the camera. As a lighter colour and then a darker colour. This one we've got a paler centre and dot clods around the edge. But it's symmetrical. It's a benign nevus. So you need to be familiar with the fact that nevi are not always all one structure. They can be multiple structures. If you can remember back to this morning where we learnt about compound nevi, so that makes sense if you think of this edge here being the junctional component, just on the surface of the skin, and then the central part of the nevus being dermal, deeper cells. And in this case we've got 3 zones again, concentric zones, making it symmetrical. This one's a repeating pattern again. Oh, it's a sudden change, isn't it? Do you see how the pattern is lost? It's no longer nice and symmetrical in either of these 2 lesions. And you can see that immediately. It suddenly strikes you, gosh, where's the pattern gone? And that's because this is cancer. And cancer doesn't follow the rules. We've still got the same structures, so if we look very carefully, we can see some lines. Maybe here's some more. We can see some dots, maybe even clods. And we definitely see structureless zones. But they're no longer forming symmetry. Same with this one. Here's some dots. I don't see any clods in this one, but there's certain dots, lines. Where are those lines? Ah, here they are. Just a tiny little bit of line left. And then we've got these great big thick dark things, which you could almost call lines as well, but they've changed to a different colour. The colours of melanoma are beginning to come in. The more colours, the worse the melanoma. So this one, perhaps we've only got light brown and dark brown. This one, we've got a reddish colour and black coming in, as well as light brown and dark brown. So the colours increase with the malignancy. So the colours of melanin are black, light brown, dark brown, grey and blue. Yellow and orange and white, really, we're talking about keratin. And red, purple and blue, we're talking about blood. And skin colour means what's left behind, keratinocytes. So melanin at the surface of the skin is black, in the middle is brown, in the papillary dermis, that's the top part of the dermis, just under the epidermis, is grey, and deeper down it becomes blue. Now the protein itself doesn't change colour. It's just the depth and the density of the pigment. So the denser, the darker, and the deeper, the darker. But you can be confused by fibrosis, which brings in some white structures, and scale. So we've seen some very blue-coloured melanoma in situ. So usually if you're thinking about deep melanoma, it's going to have blue colour if it's still pigmenting. But a superficial melanoma sometimes can have blue too if it's got so much thickness to it, even within the epidermis, that can happen. It's rare. So here to remind you of the patterns of nevi. We've got a reticular pattern, a dotted pattern, a clod pattern, and a structureless pattern. Okay, which is the melanoma? Top left. It's easy, isn't it? So with our melanoma, we lose structure. This is made up of clods. This is made up of concentric circles, or lines joined up. And this is a very complicated pattern, but it's completely symmetrical. Here, we've lost our dots, we've lost our lines. We've just got structureless, but we've got many dangerous colours. Melanocytic nevi. So the melanocytic nevi can be congenital or acquired. There's a sort of intermediate group, which we call congenital sometimes, but then it's not present at birth, so it's a pretty funny name. So the word tardive has been brought in to say, well, they look like congenital nevi, but they occur later in life. And they tend to occur before the age of 10. So children's nevi are inevitable. They turn up whether they've been in the sun or not, and they occur in all skin types. However, there are more in light-skinned children, and it is thought that therefore a tiny amount of light might be enough just to trigger collections of nevus cells in the dermis to proliferate and form what we recognize as a mole. We also look at the histology. Are the nevus cells on the junction between the epidermis and dermis? Are they in the dermis, or are they both? And then the blue nevus is a bit special, deeper and different types of cells. There's far more types as well, but that's just a beginning. So when we look at the dermoscopy of benign nevi, they're symmetrical in structure and colour, and if they have more than one pattern, then there's symmetry. And if you've got 3 patterns, it has to be concentric, otherwise it's not symmetrical. So that symmetry in structure can be due to reticular pattern, clod pattern, or structureless. The junctional nevus is a reticular pattern, and the dermal nevus is either this clod pattern or structureless, but you can actually have a structureless junctional type as well. Reticular pattern versus parallel pattern. So reticular pattern is a junctional nevus on most of the skin, but when it's on the palms and soles, you can't have a reticular pattern, you have to have a parallel pattern. This one is showing some pigmentation occurring within some of those sweat duct pores. Not all of them, some of them are still white. The radial pattern is probably less common. This is, you heard Peter talk about it, a darker nevus, I think he called it. These are not uncommon, and they're always multiple. Sometimes people have hundreds of them. And another name that I've been tending to use is lentiginous nevus, because that's the name I was taught by Jean Bologna. Here's these radial pattern, actually very, very common part of this darker type of nevus. Not the distinct radial pattern of the spits. You'll see things like this a lot. So we get a lot of referrals for patients with little dots on them, and we say, which one was your doctor worried about? And they look and they say, actually I don't know, because they've got hundreds of them. So that we know that doctor didn't examine the patient, because if they have, they would know that patient just is made up of loads of dots. So why pick on one in particular to worry about? It's their pattern of benign nevi. The dotted pattern is less common. The clod pattern is the childhood pattern that tends to be lost in adult life. The cobblestone is those papillomatous nevi on the trunk, the ones that get caught on clothing, completely harmless. But they do change in the 20s and 30s, so they come from flat to papillomatous. So at some stage, some patients are going to come to you and tell you they've got a changing mole. So you need to know that's a normal phenomenon. The reed pattern is, of course, rare, where we have these distinct pseudopods in the radial pattern all the way around, usually excised. Structureless nevus, the blue nevus is the one that everybody recognises, but you could also have structureless brown. This is a Clark nevus. So a Clark nevus is acquired. It's not one of those congenital types. It's very superficial. It can be just a junctional or a thin compound nevus, but they are due to sun exposure. So Clark nevi are most common on the upper back. So you look at a patient who's an adult, and you see they've got loads of flat nevi on their upper back. They're Clark nevi. They're frequently excised by people who think they must be melanoma because they don't know such a thing exists, but they're extremely common. The pathology comes back dysplasia, and then the patient is told, I saved your life! You had a dysplastic nevus. No, you didn't, because all their nevi on their upper back are dysplastic nevus. It's another name for a normal nevus. The problem comes when the pathologist says with marked dysplasia or severe atypia. Now, what he's really telling you is he doesn't know. It could be a Clark nevus, it could be a melanoma. He said he gets bets, probably a Clark nevus. I'll call it a dysplastic nevus. That sounds as if it shows that I don't know what I'm doing. But a pathologist will never say, I don't know. Have you noticed that? We, as clinicians, say that many times a day. We're saying, Mrs. Jones, lovely to see you. No, I don't know what's wrong, but I do know what to do. Yeah, we do that all the time. But a pathologist never does that. They have to write something on the bottom line. So they hedge. And be aware of that. That if they're saying something is severely atypical, it means they haven't a clue and it could be a melanoma. So remember that. Because a normal Clark nevus or dysplastic nevus has no atypia. It's typical of that. Now, its pattern is dysplastic, but that is its pattern. And it has a pattern. They can change. And we showed how they get dots around the edge and they expand. That doesn't make them malignant. Which of these is a blue nevus? Somebody is finding this one difficult. Who should we ask?
That's me.
Carrie, what did you think?
Well, I would say the one on the right is...
Yep, because? Blue. What colour is this one?
It's more purple. So.
It does have a purple tinge, no doubt about that. But otherwise they're pretty similar. And if only I could find the right picture, I'm sure I'd be able to find one that was blue. So, Kerry, is there a test you'd like to do to help with this diagnosis, do you think? This is a clinical view. I haven't got the Dermoscopy here. Kerry would like to say, she hasn't quite got it out yet, she'd like to say, I'd like to see the dermoscopic view. Was that right, Kerry? Yes, it was. So we'll look at the dermoscopy and see if it helps us. Okay, they're quite different, aren't they? So many angiomas are actually rather blue. In the photograph you can see it as purple, but I bet if you saw that person in your surgery you'd see blue, not red. But when you get the dermatoscope out, this is made up of, Kerry, read it out please.
Lots pattern.
Yeah, and the conventional word was lacuna, but the modified word is the clods pattern. So it's so different, isn't it? So this is how you're going to describe this one. This is your blue nevus.
Structureless pattern of rotorua.
Yes, structureless pattern, and it's a what colour? And it's still blue. Whereas this one has become much redder purple on the dermoscopy. And do you see how it's made up of discrete structures? Okay, next. Okay, mixed patterns in nevi. So we would say a nevus had a mixed pattern if it had 2 or 3 patterns. But it has to be symmetrical in structure. It can be any shape you like, but the structure should be. And if it's mixed, it's going to be a compound nevus. So here's some examples. We've got a structureless centre and we've got a reticular pattern around here. Here we've got one of those darker nevi. Peter, I see you've crawled in. This is another term for the same thing. That's from Bologna, the lentiginous nevus from her signature nevi. So add to your list of names for these. Yep. We can see lines and clods. So this one's got lines around the edge and maybe structureless, I don't know which you see. And this one has rather a strange congenital nevi. Now, congenital nevi, when you look at the dermoscopy, are often very strange, so probably it's best not to, when you're a beginner. Leave your congenital nevi for later when you've become more experienced. Just ask the question, how long's that been there? And most people will say, my mother said I was born with it, but occasionally people haven't a clue. So in this case, we've got a structureless centre, we've got those clods around the edge. What can we predict will happen with this lesion? It's going to get bigger or smaller? Bigger. So this one's going to grow. What do you think this one's going to do? Also going to grow. Because it's got clods around the edge. We have to remember back to this morning. We've covered a lot of ground this morning, haven't we? So if we have clods, dot clods, remember I said sometimes it's difficult to say whether it's dot or clod. I think we can call these dots and those clods, but they come to the same thing. So here's an example, 2012. We've got a Clark nevus with some dots around the edge, and it's grown, and it's beginning to lose its dots. Now, it's taken a long time to do that. Now, that's not... Hello. Looks ugly, Well, you have to put it in context. So what we have to do is take a history, examine the patient, and see the pattern of nevi. Now, you're often going to find that they have several lesions looking the same. And it's really important when a patient draws up their sleeve and says, is this all right, doctor? And you think it's all right, but you're not sure, to say, hey, we need to look at your whole skin. I haven't got time today. Let's make you, I'm coming to the reception with you, and we're making an appointment for next Friday on the afternoon. Please come. Give them a full examination, and then put it in context and say, look, Mrs. Jones, this is really just the same as you've got on the other arm. Or maybe you've got 6 or 7 looking like this. Are you going to cut all 6 or 7 out? What would be the point in that? On the other hand, if it's solitary, you might find it much easier to excise it than to watch it, and that would be the safe thing to do. Or you would refer to a teledermoscopy service if you're lucky enough to have one. Okay, so this is an example of a benign change, and we're going to see some more of those later. Let's talk about excising lesions. I think some lesions do need excision. Do either of these need excision? White, orange, both, or neither? Okay, we've got lots of whites coming up and a few oranges. Emily, who should we ask? Jonathan, your turn. Which one are you going to cut out?
I can give it A.
Uh-huh. Why?
Just because it's got a bit of chaos.
A little bit, yeah.
And it's got a bit of close as well.
Mm-hmm.
I'm not so sure about B. What's the pattern?
Yeah, it does, because we've got one pattern around the outside. What's the pattern around the outside? Reticular? Yeah, well, we've got the same pattern of this one around the outside. Yeah, and the inside?
Is that just the structures?
Structureless, yes. If you can't see dots, clods, and lines, or you're not sure, call it structureless. So it's fairly symmetrical. This one has more structure in the middle, and we've got the funny blue colour coming in. Do you see these thick lines here? What are they? Hairs. Right. Does that help you at all? Congenital nevi can look very, very funny. So congenital nevi often have hairs. In this one actually was excised and was turned out to be benign. So that's always helpful. But again, you may find that there are several lesions looking the same in a patient. And that's very reassuring. But the thick, oops, gone a bit farther than I meant. The thick lines don't tell us whether it's benign or malignant. They tell us that there's hairs in it. And thick terminal hairs within a lesion tells you that it was present before the age of 10 years in age. So, because they're not really melanocytic nevi at all, they're organoid nevi. That's to say you've got growth not just of melanocytes but also of other components of the skin. So sometimes they're very warty, sometimes they're very hairy, but they often have a few thick terminal hairs. And this lesion was funny and stable forever. Is it easier with this one? Let's have the cards up. You've got to make your minds up. That's what clinical medicine's all about. Make your mind up. And you've got 15 minutes to examine the whole patient. Okay, so we definitely don't like this one. We might have to start again if we got to the end of the list. Claire.
So A is the one on the left.
Mm-hmm.
So it's got the regular circular pattern, but out of that.
Yes, but really they're skin colour or white clods. Yep.
White clods, and then you've got the quite irregular, pigmented, structureless, quite worrying looking.
This here. So I think if we put that all together, we'll say it's asymmetrical in colour and structure. That's the first thing to say. Whereas this is symmetrical in colour and structure. This is asymmetrical in colour and structure. It's a very unusual melanoma, actually, but it is a melanoma. So it's got clods in it, it's got structureless zones, and a few lines. What colours can you see?
Black and brown.
Black, brown,
A bit of grey.
grey,
And in the top part, a bit of purpley red.
purple. Here, we've got some blood vessels coming in there. They're really weird looking, aren't they? If you look at the blood vessels of this nevus, are you going to hazard a type of nevus for this one? One of those floppy ones. We have used the word already, papillomatous nevus. Okay, it's papillomatous nevus, and all the clods are the same. They're different in size and shape, but really, basically, it's all clot pattern. You see the blood vessels? They're not as sharp as in here, and they're all more or less the same, and they're short curved lines. Can you draw us a short red curved line? And by conventional pattern analysis, that's called a comma. And a modified pattern analysis, it's called a short curved line. You can use either. I think comma is pretty easy, so comma's fine by me. Whereas here we have curls and squiggles and blotches, and here we almost have a circle. Very unusual pattern of blood vessel. When we see lots of different types of shape of blood vessel, we might call that polymorphic. Quite often there's dots. We're not seeing dots in this one, but dots and linear pattern. So that's the short curved line. Okay, so in a nevus, we're looking for symmetry. Something happening in the middle and something happening on the edge. Or if it's in 3 zones, it must be concentric. Symmetry, 2 or 3 patterns. Which of these two is symmetrical? Okay, most people have got white. Where have we got to? Yes, which did you choose? Neither is symmetrical. Right.
Well, the first one, so A,
Yeah.
does have symmetry in the middle.
Mm-hmm.
The outside looks a bit fuzzy.
Okay, Emily, can you draw us an eclipse nevus? Remember what that looks like? A sun in front of a moon in front of the sun. So full eclipse. So we've got the sun. A bit bigger so people at the back can see it. Big round with a big round outside it. Okay, so that's the moon encounter. Now get your rubber, if you've got a rubber. Okay, rub a little bit out here and there. Yeah. See how it's just lost a bit. Now, Peter told us this morning how some nevi fade away. So what's happening to this nevus here is it's beginning to fade. Okay, so it might have been continuous at one stage, but it's lost bits. And that doesn't mean it's not symmetrical, really, because this is biology, not mathematics. So we have one structure in the middle and another structure round the edge. And it's deliberate, of course, to put this one in here, hoping that Mystery would absolutely tell us exactly what she did.
Clinically, how we know it has lost bits rather than bits are growing off it?
Bits are growing off it. Because these bits all look the same. If you just had one bit that looked a bit odd, I think that would be worth watching. But really, it looks as if it should be a complete circle around it. It takes practice, but again, you're going to examine your whole patient. You're going to take a history, you're going to examine your whole patient, you're going to see the pattern of nevi in that patient, and you'll find that they have lots of compound nevi with a central area looking like this and a surrounding area looking like this, and some of them will have complete reticular pattern and some of them will have gaps. And then you think, oh, that's okay, it's just fading out, no problem. This one is a melanoma. So can you describe this for us, Mystery? No, this one here? Because you've already told me about this one. Tell me about this one.
Well, I thought it was a reticular pattern, but more pigmented in certain parts and less pigmented in some other.
Yes, so a melanoma can certainly have a reticular pattern, but we've lost our symmetry. So the symmetry of the shape, but that doesn't count. The symmetry of the colours. So here we've got a bit on the edge, so it's eccentric, it's not in the middle. We've talked about darker in the middle being okay. Here we have darker on the edge. Now that on its own wouldn't be enough, but here we've lost the colour altogether. You see how there still is a structure there, but it's lost its pigment. So these melanocytes in this portion are no longer producing melanin. And this is tiny. All the lesions that we were seeing today are at the same magnification, but this is an early melanoma. So don't worry if you miss it. It'll still be there next year for you to catch next time. So we better talk about melanoma, because we've been talking about nevi up until now. So a melanoma can be any pattern, any colour. The more structures and more colours, the more likely it's melanoma. The thing that we're looking for is asymmetry of colour and structure, which we call chaos for today's exercise, and you then can look for clues. Actually, the clues are very unimportant. It's asymmetry of colour and structure. And one of the many algorithms that there are for diagnosing melanoma says that you get 2 points for asymmetry of colour and structure, whereas anything else that you're looking at only gets 1 point. So, high suspicion of cancer. Has any of you seen this before? This is from the Ministry of Health, and they're expecting you to use it. But they haven't shown you it yet for some reason. It was published in 2013, but they forgot to tell anyone. So this is for you to refer. It's a guideline for referral. You can have A, B, C, D, E, personal history of melanoma, family history of two first-degree relatives under 40 diagnosed with melanoma, and each of those gets a point. If you've got 3, then you can go for high suspicion of cancer referral. That's the 14-day rule that they can't comply with. Or you can just say it's suspicious for melanoma on dermoscopy, and you can forget all those ones. So let's go through each of those in turn. Red flag A stands for asymmetry of colour and structure. Which of these two? You're only allowed 1, by the way, for this exercise. Okay, do we have anyone left on the list? Which did you choose? On the right? Yes? It's clearly asymmetric. Well, it's asymmetric if you look that way. So it's in one axis. It's quite symmetric in that axis, in fact. So asymmetrical in one axis. But that might be good enough because that lesion is a melanoma. So this is a speckled lentiginous nevus. We had one of those before. We've got a benign background, slight brown, and then we've got a repeated pattern, which is either reticular or structureless, however your eyes are looking. Whereas this one, the more we look at it, the more we realize that it's not so symmetrical as we thought in the beginning. Let's look at that top there. It's quite different from that. And that side is quite different from that. And even those darker blotches are different from each other. And that was melanoma in situ. What about this one? B is for border notching or irregularity. Okay, we've gone for whites. Most people think that the one on the left, that's because they know it's melanoma. Who are we going to? Jodie. Jodie. You chose which? A, because? Ill-defined and irregular, but do you think this is ill-defined and irregular too, by any chance? Because I do. So the purpose of this picture is to say that border irregularity is a very poor discriminator between melanoma and benign lesions. And I can show you that border actually can be very confusing. Peter wants to contribute to this. Irrelevant. Me too. Absolutely, and I tried to get rid of the B, but nobody could think of something else to put. And if you got A, C, D, you really had to put B in too. They insisted upon it, and I was overruled. Yeah, and this B results in many unnecessary referrals, and we wish it would go away, but it's still there. So there's plenty of melanomas with a perfectly round or not, and you can actually have a fading border, or you can have a sharp border, or more often you have a bit of both. And in nevi, irregular border is normal. So forget B. Now here's another example. We've got some congenital nevi here with very strange shapes. So please ignore B. Let's go for red flag C. Does anyone know what C stands for? Colours. Okay, so lots of colours, variable colours. Which of these two has or have variable colours? Okay, most people think both. That's good. Have we got anyone else on the list? Can you tell us about the colours, Carolyn? Yep, multicolours of both. And when we look at dermoscopy, we'll see even more colours. What do you think each of these lesions is? Melanoma? Yeah, what about this one? Suspicious. So suspicious of melanoma. What else could it be? Too thick for a melanoma? Two things? Or it could be a collision of two things? What two things? So you're thinking seborrheic keratosis is certainly very dry on the surface. So let's look at the dermoscopy. Okay, so the easy melanoma turned out to be pretty harmless. In fact, once you cut it out, you can forget about it. But this one could have been missed because it looked like a seborrheic keratosis. But it's multicolored. So seborrheic keratoses can also be multicolored, and they can be really hard to tell apart. So listen carefully to the patient. If in doubt, refer or cut it out. But don't miss your nodular melanoma. So here it is on dermoscopy. The colours are much easier to see, and we've got multiple structures coming in. We've got a lot of white in both of them. These are true whites because they're whiter than the surrounding skin. We've got black, we've got two shades of brown, we've got a bit of pink coming in. Same in those ones. Asymmetry of colour and structure. The structures we have in this, we've got a bit of a reticular pattern, we've got structural zones, we've got some white network. In this one, we've got lots of white network. We've got some clods over here, structural zones. Asymmetry of colour and structure. Now, red flag D in the New Zealand high suspicion of cancer is not D for diameter. If you were reading very carefully, you would have seen D was for something else. Anybody notice? D for? D for different, okay? D for duckling. Only we're in New Zealand and we'd rather have the black sheep. But anyway, that doesn't begin with D. So D for different. So the ugly duckling sign is the most important. You must examine your patient, you must take a history, and you've got to see the pattern of the normal for that patient in order to identify something that is D for different. Okay, since you are in the front row, Perry, I'd like you to point to the one on the left that's different. Okay, and Claire, can you point to the one on the right that's different? Okay, it's not that hard, is it? Nearly every melanoma can be spotted from the end of the road. The problem is, that was a seborrheic keratosis. And seborrheic keratoses are really hard at times to differentiate from melanoma. We have to learn SEBKs. So the ugly duckling sign, very important. We spot something that looks different from the other nevi. We look at it closely. We get out the dermatoscope. We find it's quite different from the others on dermoscopy as well as clinically. And we find that it's lost its pattern. It's asymmetrical in colour and structure. Okay, red flag E. Red flag E is E for evolution or change. Which of these has E? Can I remind you that if you don't know or it doesn't, the answer is like this. Could I have you all doing this, please? You can't see E on this picture. E is for evolution or change. Now you can. So this has changed to this. What's the diagnosis? Melanoma. This has changed to this. They are at the same magnification. What is this? Is it a melanoma? No. What is it? A nevus. So nevus can grow too. So that's over a period of 3 times it's grown a bit bigger. This is over a period of 1 year, it's grown a lot bigger. So melanoma can grow quickly. But actually, melanoma can grow extremely slowly too. And we might see something like this looking almost the same a year later. So we just have to be a bit careful of that. Should we have removed it in 2010? Yes. Why didn't we? Oh, that's a dermoscopy picture. We had the picture. Patient didn't come back, possible. Any other suggestions? That's not infrequent. Not infrequent that they don't come back. I've got a mole map report I did last week. Patient has been 4 times. On each occasion, this is a melanoma, go and have it cut out. Still coming. Having it monitored. People are very strange. Any other ideas? No other ideas? Incompetence as a dermatologist? Might have been Peter. Did you diagnose this one, Peter, and miss it?
Which one?
This one. That's 2011. I don't know. Any of us could. We're always missing them. Peter, give me some examples why we miss melanomas. Yeah, we miss them all the time. It's very depressing. We miss them mainly because these are in patients with very many moles and nevi, and we're looking and we're looking and we're looking and we blink at the wrong moment and we miss it. That's one reason. They might have 200 nevi that we're looking at. But more often, they've got loads that look like this. This is a very sun-damaged patient, and he might have 50 lesions looking like that. But it's only E for evolution that says, oh, that one needs to come off because it's changed. So here's another example. Or is that the same example? Yes, it is. I just do. So I'd like you to recognize, we've only got a few minutes, so I've got about another 300 slides to show. Vascular lesions are red, purple, or blue, right? They can be lines, red lines, or blue lines. Telangiectasia if they're red, venulectasia if they're blue. They can be clots. These are proliferative things. They can be congenital or acquired, so we've got a congenital one on the left and an acquired one on the right. Red clots. We've had the one on the left or similar to it before. Actually, it's a different one, but parallel red dotted pattern. And here's lots of red clots. They're completely harmless. Once you've learned that, you don't need to worry. Here's some more. This one's a lymphangioma, so it tends to have a bit of yellow around it. You could have its structureless pattern in a venous slake, some pyogenic granulomas. So here's some dots and capillaritis, here's some clods and purpura, so bleeding. This might have been a patient I saw yesterday who had systemic sclerosis with blood clots on the cuticle. This is under the strata corneum, but they're red, purple, or blue. Sometimes it can be almost black, as this one on the right. Which of these is angioma? Okay, we've got the one on the left because it's red, very good. The one on the right is a nevus, actually. But the pattern on dermoscopy, it's much easier to tell. We've got the red clods, we've got the blue clods, but you see that bluish colour, not because it's a blue nevus, but because this is a dark-skinned patient, and sometimes their nevi look blue. We see the blue nevus as being the only blue we see in benign nevi in white-skinned people. The other thing I'd like you to just be aware of is dermatofibroma. So dermatofibroma is not actually a neoplastic lesion, it's a fibrous reaction in the dermis. And it's often pigmented because you get some hyperpigmentation. And it feels like a little button in the skin. And when you squeeze it or pinch it, the skin dimples. Whereas if you pinch a dermal nevus, it goes outwards. And sometimes that's helpful for telling the difference. They're both benign, of course, so perhaps it doesn't matter. So they're a firm dermal papule. Now, the most common dermatoscopic sign is a white centre. So this isn't quite white, but it's paler, and this has a reticular pattern around it. You'd be forgiven if you thought it was a nevus. It doesn't matter, they're both harmless. Symmetrical. This more common pattern on polarized dermoscopy shows a sort of reticulated white centre and a fading out pink or brown structureless pattern. Both dermatofibromas. Symmetry. Important to know about them because there is a type of melanoma that can look a little bit like this, but without the symmetry. Which of these is a dermatofibroma? Okay, we've got the one on the left is correct. The one on the right actually has a white. So what I really wanted to show you with this picture is that white in the centre, dermatofibroma, but nevi sometimes have white all around the edge, and that's the halo nevus. And to spot that, and halo and nevi are seen in the congenital type tardive nevi. Solar lentigo, you'll be familiar with them because a lot of you will have solar lentigos. They are flat, circumscribed brown patches on the sun-exposed skin, so certainly on hands and faces. And we see them in all skin types, black, brown, and white. More prevalent in white because we get more sun damage. They have a sharp edge. Now on dermoscopy you can see various different patterns, and they're not completely uniform across the whole lesion. Here's some with some circles. They tend to be a little bit sharp around the edge. That's very helpful. Again, sharp around the edge even when they're very pale ones. Different patterns. Moth-eaten shape. Which of these do you think is a lentigo rather than a nevus? One here is a lentigo, the other is a nevus. Great. So to remind you that the lentigo is an acquired sun damage spot. It's actually keratinocytic, so you've got proliferation of keratinocytes, often pigmented because those keratinocytes gather up pigment, whereas the nevus is made up of melanocytes or nevus cells. We've only got a few minutes left, so we have to cover seborrheic keratoses. You're familiar with them because they're stuck on warty plaques. 90% of people over the age of 40 have a seborrheic keratosis, and some have thousands of them stuck on. Very variable in appearance, very difficult to distinguish from melanoma when they're solitary, ugly ducklings. The characteristics are sharp border. On dermoscopy, we see these orange, grey, brown, and black clods, and we also see white and yellow ones, thick curved lines. Clinical pattern, seen a million. So let's look at the dermoscopy. Lots of orange structures. They're very superficial. You could take them off with tape. Irregularly distributed, irregularly shaped, mainly orange, but they can be grey or brown or black. White ones tend to be oval or round. Highly variable seborrheic keratosis, very sharp edge, lots of different papillomatous patterns, ugly patterns, bits of keratin stuck in the middle. They change. So it's quite normal, if you photograph a SEB-K, to see that it's different. So it's absolutely pointless. If you're sure it's a SEB-K, don't monitor, because it's going to be different. So what's the point in monitoring? The only reason for monitoring would be if you're not absolutely 100% sure. Which of these is SEB-K? Only one. Easy. Why? Do we have any names left? The one on the left, Louise? Grey stuff? Stuck on. Very sharp edge, stuck on, and warty surface. So it's multicoloured, it's large, but it's warty. Now, you can have a collision with a melanoma, so you could have a SEB-K that had a melanoma on top of a melanoma, and some melanomas have a SEB-K-like appearance, just to confuse you. So if in doubt, refer or cut out. But mostly it's easy. Melanomas are generally smooth. Not always, but generally. Right, well, we've only got 2 minutes left, so I'm going to stop, and I'm going to miss out 100 slides. Obviously, I timed it wrong. I usually do this in 4 hours, and we were only given 2, so that's why we've only got to 180. So that's good learning, isn't it? It's 180. But I will just show you this picture. So, pigmented skin lesion, symmetry, 1 or 2 colours, benign. Asymmetry of colour and structure, not shape, colour and structure. The more colours, you're either dealing with a seborrheic keratosis or a skin cancer. We didn't have time to deal with keratinocytic skin cancers today. But this PowerPoint is probably going to be recorded, and if you really want to look at the other 180 pictures, you're very welcome to. I want to go to the quiz and see whether it has been helpful at all to turn up this morning. Okay, hands up for A, nevus, B, melanoma, C, seborrheic keratosis, or D, cell carcinoma. That's supposed to be basal. I don't know what happened to the B. This one, A. Gradually we're getting more and more hands. Yes, it's a nevus. This one, we didn't do basal cell carcinoma, but this is what this is. It's a BCC. So how do you know? Well, it's got sharply focused branch red lines going into the middle. It's got white structures. It's also got like a greyish colour, which is typical. This one, A, B, C, yep, C, seborrheic keratosis. Lesion 4, 5. A? Yeah, it's a nevus. This is an acral nevus. So we've got the parallel pattern. We've got very prominent sweat ducts showing up as brown. Anybody know this one? A? B? Some people think it's a melanoma. C? D? It happens to be a pigmented basal cell carcinoma, but if you thought it was a melanoma, that's fine, you're going to cut it out, so that's the main thing. The only thing is that we do actually have a different margin for basal cell carcinoma. So if you see a lesion suspicious of melanoma, the margin is 2 millimeters for the excision. Whereas if it's basal cell carcinoma, the margin is larger, usually 4 to 5 millimeters, because they can be very tricky to excise, basal cell carcinomas. But it doesn't matter. If it's 2 millimeters and you excised it fully, there's no need to do anything else. But if it's incomplete, obviously, if it's a basal cell carcinoma, you need to go back and take some more off. Lesion 7, A, B, C, D. Most people haven't a clue. It's a nevus. Why is it a nevus? Well, you don't see this brown reticular pattern in basal cell carcinoma. I think some of you wanted to call it BCC because it's pink. Nor do you see that very sharp edge. A basal cell carcinoma is cancer, so it's kind of spreading out. And this is actually clinically, I haven't given you the clinical picture, but the clinical picture, you wouldn't have even looked at it with a dermatoscope. It was just a very banal, normal nevus. So dermoscopy can give us the wrong answers when we're a beginner. Remember, take a history, examine your whole patient with the naked eye. Then get out your dermatoscope. Use your dermatoscope over the whole patient, looking at the harmless lesions first. What is the normal pattern for this patient? And then if you do see something that's different from the others, then you can get your dermatoscope out. The very last thing, the patient always thinks that's funny. This one, doctor, this one, they say, when you're looking on the other side. You know, like you look at the good ear before you look at the bad ear. Same in dermoscopy. Look at the normal before you look at the abnormal, because otherwise you're going to preconceive what you're going to do. Look at what's normal first. And then you may find that the one the patient's concerned about is also normal. It's just bigger or darker or some other characteristic that doesn't matter. This one, A, B, C. You also get some melanoma. This is a blue nevus. It does help, of course, to have a history, and this is a stable lesion, been there forever. So it's fuzzy, it's got a bit of yellow and blue. You'd be forgiven for calling that a melanoma. I was fortunate, and then we had repeated serial pictures, all of which look the same. This one, seborrheic keratosis. So we've got the orange, irregular clots, we've got some white, less irregular. This one is a tricky one. Turns out to be a nevus, but it's a congenital nevus. So we see asymmetry of colour and structure, so we have to look at it a bit more carefully. We've got an area here made up of clots, but if we just isolate that, chop it out of the picture, just look at this bit, it's all the same. This is a blue nevus, and the rest is more or less all the same as well. It's a combined nevus. Yeah, but again, you wouldn't even look at this with your dermatoscope because the patient would say, oh, don't worry about my birthmark, it's always looked like that. This one actually was excised on my recommendation because I did think we needed to be rid of it, so we didn't have to monitor it. But it was completely harmless. It's congenital nevus. Okay, so please buy my book. I believe it's on sale down below. And don't forget to check out on DermNet. I'm sorry we couldn't finish 300 pictures today, but it was a great pleasure being here. And if you'd like to look at some dermatoscopes, Emily and I can demonstrate those if you want to stay over lunch. Thank you.